Okay, so let us start one of the important topics in complete dentures, that is your posterior palatal seal area. It is one of the most important topics in complete dentures. Now, what is this PPS? Whenever we are talking about the posterior palatal seal area, we know it is the now two things we need to understand is that it is the area as the it is defined as the soft tissue area at or beyond the junction of hard and soft palate on which the pressure within the physiological limit can be applied by the complete denture to aid in its retention. Now the thing that is important is that अगर आपके पास चॉइस आती है कि इट इज़ द एरिया एट द जंक्शन ऑफ हार्ड एंड सॉफ्ट पैलेट, एक चॉइस, और दूसरी चॉइस आती है इट इज़ ऑन द सॉफ्ट पैलेट, तो माइंड यू इट इज़ ऑलवेज ऑन द सॉफ्ट पैलेट. ठीक है, डेफिनेशन में इट इज़ एट द जंक्शन बट इट इज़ ऑलवेज एट द सॉफ्ट पैलेट. एक और वन मोर थिंग आई वुड लाइक टू टेल यू इज दैट even your fovea palatini, if they are present, mind you, write down in bold letters, if it is that it is always on soft palate, it can be on hard palate, mind you, it is always on soft palate. Even fovea palatini is always on soft palate. So by definition we see that it is an area. PPS is an area. It's a seal area. It's a peripheral limiting structure of maxilla which basically aids in the retention of the denture. Okay, what is the definition of a vibrating line? Okay, now when we talk about the definition of a vibrating lines, it is an imaginary line across the posterior part of the palate जो कि हमारा मूवेबल और इमूवेबल टिश्यूज और सॉफ्ट पैलेट को जो डिवाइड करता है, राइट? दैट मीन्स and it can only be defined when we are asking the patient to say we see the soft palate moving. तो basically vibrating line की definition है कि the imaginary line that across the posterior part of the palate, marking the division, mind you, marking the division between the movable and the immovable portions of the soft palate. Now understand is that the soft palate that is immediately adjacent to the hard palate, it will be less movable, right? And as we go posteriorly on the soft palate, there are more muscles of the soft palate, so that definitely that portion will be highly movable. Okay, so the junction between the movable, slightly movable and highly movable tissues of soft palate decides the vibrating line. Okay, if we talk about the I'll just tell you the definition of anterior vibrating line and posterior vibrating line. Okay, just a minute. Okay, so anatomically, if somebody asks you anatomically what is the classification of it is the PPS, it consists of two parts. One is the post palatal seal and second is the pterygomaxillary seal. I am again saying it is post palatal seal and it is the pterygomaxillary seal. Now post palatal seal, it extends from one tuberosity to the other. Okay, it extends medially from one tuberosity to the other. Okay, one more thing I will tell you, the PPS will never be beyond the tuberosity. यहाँ नहीं होगा, it will always be contained within the tuberosities, right? Second thing, what is pterygomaxillary seal? Pterygomaxillary seal is basically the Hamlin notch area. This is the Hamlin notch area that extends laterally in the mucobuccal fold. So that means PPS is the combination anatomically. It extends through the pterygomaxillary notch, and the post palatal seal is the area that is contained medially between two tuberosities, right? So if we add both these two, it forms posterior palatal seal area. Okay, right? Clear hai? Any doubts? Let me check the chat box. If there is any doubt, kindly let me know. Any doubts? It forms posterior Any doubts? Okay. Okay, now what is the function of PPS? When we talk about the functions of PPS, we know that the posterior parietal seal area, it provides the main retentive area for the maxillary denture. Okay, now we should understand 2-3 things. Write down one of the important question. What is the phenomena by which the PPS acts? See, PPS acts by creating a partial vacuum. Write down. It acts by creating partial vacuum. It acts by creating a partial vacuum between the tissues and the denture. Okay, one more thing, why is the recording of PPS is very, very critical? The recording of PPS is very critical. Why? Because see, हम ये कहते हैं कि even if this area, for example, the buccal vestibule, labial vestibule, अगर वो बहुत अच्छे से रिकॉर्ड नहीं भी हुआ, then still it is still there are some margin of error. But while recording posterior parietal seal area, there is no margin of error. Why? Because here it is the area of the lips. It is covered by lips, drape of the lips, and posteriorly the buccal vestibule. The buccal vestibule is being draped by cheeks. So they will help you even if you have not recorded them so well. But the drape of the soft tissues will give you that margin of error. But you don't have lips or cheeks in the posterior parietal seal area. It's an open area. So that's why it's become critically very, very important if we are recording the posterior, because it's an open area, right? So that is why the recording of the PPS becomes very, very critical for the retention of the maxillary denture, and more so because it is acting against gravity, right? So it is important. First thing is it acts as a limiting area. It forms the main seal of the maxillary denture, so provides the retention for the maxillary denture, right? Okay. Now second thing is that second important function is that it prevents the ingress of the food and the saliva beneath the denture. When it is forming the seal, so it will prevent the going of this food and the saliva beneath the denture. Third thing is that it prevents gag reflex. Now there are some points regarding gag reflex which I will be which are not on this slide, but kindly understand the points of gag reflex, which many people underestimate. There are some questions about gag reflex. What are the points and criteria? I will tell you right now. So gag reflex is basically a retching sensation. It's a protective phenomena that and it has a lot of psychological component. So why recording a good PPS prevents a gag reflex? See, if we are over recording in PPS, if we are over the PPS, okay, then if we are beyond the soft palate too much, definitely the patient will gag, right? Okay. Second problem is that, see, the denture contact, if we have recorded it well, so there will be a continuous contact even when the soft palate is moving and even if it is not moving. So at rest, even at rest and at function, the contact of the denture and the soft palate is maintained. Now if you have not recorded the PPS well, what will happen? At rest, okay, the denture border, the posterior border of the denture, that is the PPS area, is being touched by the denture border. Okay, they have a contact. But as soon as the patient speaks, the soft palate moves, so the contact is broken and again it is formed. Contact is broken and again is formed. So what will happen? There will be a continuous trigger of the messages that are being formed on the soft palate, and there are a lot of nerve endings. Remember this. The nerve endings that are important, so there are a lot of trigger zones. The theory of gag is because of the trigger zones. There is a lot of firing. When the PPS is not recording well, तो contact टूटा, contact बना, contact टूटा, contact बना. So there is continuous firing on the trigger zones. Where are those trigger zones for gag? The trigger zones for gag reflex lies in the posterior portion of the soft palate and the posterior part of the tongue. Now the question that is asked lot of times is that what are the nerve components? So when we talk about the posterior part of the soft palate, we have vagus nerve, and the posterior part of the tongue we have glossopharyngeal nerve. So these are the two nerves that are important for gag reflex, right? Okay, so one thing is important is that we should have a continuous contact. Okay, right. Now one more thing that is important is that, okay, now how to prevent this gag? What are the other components? Now we all know that there is a psychological component that is there. So there are various एक तो आपने PPS बहुत अच्छे से रिकॉर्ड करना है. दूसरा second thing is that whenever we, other thing is that how to prevent gag reflex. There are various tips, there are various methods to tackle such patients. So whenever we are so whenever we are okay, so how to prevent this? So there are other methods, that one is this, to control the patient psychologically. So whenever we are controlling the patient psychologically, there are various therapies. One is the distraction therapy. Distraction therapy में क्या होता है? In the distraction therapy, we are actually distracting the patient, okay, by you must have seen while you are recording the PPS or while you are making the final impression, we ask the patient to look at some point, to just raise the hands, to just move the feet like this, so that the patient is distracted and the psychological component is being taken care of, okay, till the time our material is setting. Second thing is that there is another therapy that is known as desensitization therapy. Desensitization therapy works upon is that डर के आगे जीत है. मतलब कहने का मतलब है कि वो एरिया को अगर हम किसी तरह desensitize कर दें, जो कि एरिया बहुत sensitized था, so what will happen? Definitely जो trigger हो रहा था वो बार बार नहीं होगा. It get used to it. So such patients we can just somehow, if we can make a primary impression and on that very cast we can just give a finished and polished base to the denture and ask him to wear for 5 minutes, 10 minutes, whatever time. So what will happen? If because it is extended in the soft palate area, so the patient will get the feel of it always. Patient को पहनने दो, अच्छा खासा finish polish base, denture base दो पहनने के लिए, बस that's it, तो उसको आदत हो जाएगी. Second thing is that there was an initial therapy that is known as the marble roll technique. We take a marble, कंचा होता है, बंटा होता है, हम उसे PPS और टंग के बीच में रोल, but it was a very it was not a very safe therapy. Even we can use the thumb pad and can just do the massaging of the, so these basically will desensitize the soft palate and can prevent the gag reflex. Another thing that we can do is that we can ask the patient to just take antiemetic half hour before the procedure. We can use antiemetics. Always use these procedures when when others are pharmacological means are the last resorts. You can also just inject the LA or just use the topical anesthetic on the soft palate. That also will numb the nerves and can help. One more clinical tip that I want to give you is that clinically, if you want to prevent the gag reflex, just take a pinch of salt and just add it on the just place it on the tip of the tongue. It helps a lot, right? Another is that you can use antiemetic, as I told, half an hour before the procedure, okay. Plus you can go ahead with the procedure, right? Now what is the now there are two things, anterior vibrating line and posterior vibrating line. So the anterior vibrating line, when we are talking, the anterior vibrating line is the imaginary line located at the junction of the attached tissues of the hard palate and the immediately movable tissues of the immediate adjacent soft palate. Okay, so if you can see that it is the shape of the anterior vibrating line, if you can see on the on the screen, it is actually cupid bow shape. Why it is cupid bow shape? Why? Because it follows the contour of the posterior nasal spine. So whenever it moves, it follows the contour of the posterior nasal spine. Okay, got it? And the posterior vibrating line, if you can see, I'm moving my cursor on it, so it is relatively flat in contour. Okay, it is relatively flat in contour. तो क्वेश्चन आता है कि आपका डेंचर कहाँ तक एक्सटेंड होना चाहिए. रिमेंबर दिस दैट योर डेंचर शुड एक्सटेंड 2 mm बियॉन्ड द पोस्टीरियर वाइब्रेटिंग लाइन. राइट डाउन, द डेंचर आइडियली should extend 2 mm beyond the posterior vibrating line. Okay, got it? So how do you record the anterior vibrating line? We can record the anterior vibrating line by asking the patient to say ah in short vigorous spurts, exaggerating. Generally patient bolega ah like this, right? Another method is Valsalva maneuver. The anterior vibrating line can also be recorded by Valsalva maneuver. How do we do Valsalva maneuver? If we just lightly close the nostrils, okay, and we just try to blow through the nose, okay, and the nostrils are closed. We try to blow through the nose, so whole of the pressure is directed on the soft palate. So when the pressure is directed on the soft palate, so the soft palate is directed, in the most functional position, downward and forward position. Okay, one more thing is that whenever we are recording the PPS, again I am saying, whenever we are recording the PPS, अब मैं देखता हूँ बहुत सारे स्टूडेंट्स जब भी रिकॉर्ड कर रहे होते हैं तो उनका पेशेंट का माउथ ऊपर होता है ऐसे. पेशेंट का जो मुंह है वो ऐसे होता है, ऐसे ऊपर की तरफ. भाई ऊपर की तरफ जा रहा है तो हमारा जो सॉफ्ट पैलेट है वो तो ऊपर चला गया ना. बट वी वांट आवर सॉफ्ट पैलेट टू मूव टुवर्ड्स द पोस्टीरियर पोर्शन ऑफ द special tray, right? So we have to be careful is that we tilt the head of the patient. If this is the FH plane, whenever we are recording the PPS, it should be 30 degrees down the FH plane, and then we can ask the patient to say ah, or we can go for the Valsalva maneuver. Now there is an important question, that why do we do this? Why do we ask the patient to tilt the head 30 degrees down the FH plane? Why? Because whenever we do that, if you can also see that whenever we are just tilting the head 30 degrees down, your soft palate will move in the most downward and the forward and the most activated position. And there is another reason is that whenever we do it, so the soft palate and the posterior portion of the special tray forms a closed compartment. So the material, the free flowing ZOE and the saliva doesn't flow into the throat. So it forms a choke or a block कि जहाँ से हमारा material और हमारा saliva it won't go into the throat. So it is important that we ask the patient to just tilt the head 30 degree down the FH plane, Frankfurt horizontal plane. Posterior vibrating line, as I said that the posterior vibrating line is an imaginary line, if you can see this. Okay, so it lies at the junction of the aponeurosis of tensor veli palatini muscle and the muscular portion of the soft palate. इसके पीछे जो एरिया है वो हाईली मूवेबल एरिया आ जाएगा. ठीक है, तो बेसिकली आपको जो लाइन मार्क करनी है वो मार्क करनी है जहाँ पे हमारा एरिया बिल्कुल भी नहीं हिल रहा और जहाँ पे थोड़ी बहुत मूवमेंट है सॉफ्ट पैलेट की. That will be decided by your we ask the patient to say ah in short vigorous we ask the patient to say ah in a very normal unexaggerated manner, right? ठीक है. Then there are two terms. One is so basically your PPS is basically what? It's a post dam area. Write down. It is also called as post dam area. ठीक, it is also called as post dam area. So there are two terms, under post damming and over post damming. So when we are talking about the under post damming, so it is basically that you are have not, either you have not reached the PPS or you are short of PPS. Over post damming is that either you over record it or you are actually very going far forward and recording even this area, right? That is not right. Okay, okay. I'll just 2-3 things just write down. What will happen if you apply too much of pressure while you are recording the PPS? What will happen? See, this is a soft tissue area, so it might become erythematous. You might cause injury to the soft area. Then second, if you over record it or you over pressurize this area, what will happen? There will be a rebound effect and it might cause dislodgement of the maxillary denture. तो कभी भी इस एरिया को ओवर प्रेशराइज या ओवर रिकॉर्ड नहीं करना है. रिमेंबर दिस. गॉट माई पॉइंट? गॉट माई पॉइंट? ठीक है. So what you should do is that you take a T-ball burnisher, mark it with the indelible pencil. Okay, just how to record the Hamler notch? We just take this instrument, V-shaped instruments, and from the middle of the, for example, the ridge, we go just backward, and then we'll find a dip. So wherever you find a dip, that is your Hamler notch area. Remember that the Hamler notch is a soft tissue, connective tissue area, areolar connective tissue, that is present between the posterior part of the tuberosity and the pterygoid humulus. Okay, so this area is an important area, okay, where the posterior portion of the denture will end. Okay, then we ask the patient to say we will see that we will mark the junction of the immovable and slightly movable part of the soft palate, so that might be telling the junction of the hard and the soft palate, right? We can see even we can check the compressibility of the soft palate with the help of T-ball burnisher, and we can mark the anterior portion of the extent of the anterior vibrating line. Okay, got it? And the thing is, when we are marking it, we can also check, we can transfer this mark on our special trays which might be overextended. So we should always see that that our tray should be in contact with this area. It should not be too much over and should never be under. Okay, so just we can just mark it like this. Then there are various classifications according to Boucher. The patient, there is a class 1A. It says that, देखो याद रखना, class 1, class 2, class 3 Boucher classified. तो जितना ज़्यादा हार्ड पैलेट के लेवल पे सॉफ्ट पैलेट होगा, that means we are getting much more area of the PPS. The more broader the area of the PPS with minimal muscular activity. Again I am saying, जितना ज़्यादा एंगल या I should say that this is the hard palate, जितना ये इन लाइन विद हार्ड पैलेट रहेगा सॉफ्ट पैलेट, उतना ही हमारे लिए बेहतर है. इट इज़ ऑलवेज बेटर. बट जितना ये और एंगल हो गया सॉफ्ट पैलेट का, उतना ही हमारे लिए रिटेंशन इट विल बी कॉम्प्रोमाइज्ड, राइट? तो क्लास 1 इट इज इन दिस सॉफ्ट पैलेट इज इन लाइन विद द हार्ड पैलेट. इट इज ब्रॉड, shallow, rather horizontal. We are getting much more area to record of the PPS and with minimal muscular activity. So that means it is class 1. Class 2B, okay, it is an intermediate. If you see that class 1, class 2 and class 3, तो क्लास 1 में देखो कहाँ से, दिस इज हार्ड पैलेट का जंक्शन है, कितना एरिया मिल रहा है रिकॉर्ड करने का, बहुत ज़्यादा. क्लास 2 में इंटरमीडिएट, क्लास 3 में एकदम से इट फॉर्म्स द हार्ड विद द हार्ड पैलेट. The soft palate forms there is a very acute angle. So that means there is a lot of muscular movement. Normally class 3 soft palate, it is seen in the दिस इज, इसको हम सॉफ्ट पैलेटल थ्रोट फॉर्म भी बोलते हैं या सॉफ्ट पैलेटल फॉर्म्स भी बोलते हैं. ओके, सो इफ यू सी अ क्लास 3 soft palatal form, so it is found in V-shaped palates. That is why in V-shaped palate you don't see excellent retention, you get a very poor retention. So if somebody asks you, class 3 soft palate is associated with V-shaped palate and poor prognosis for retention of the maxillary denture. Got it? तो more acute, जितना ये in line होगा soft palate पे, उतना ही अच्छा होगा हमारे लिए. जितना एंगल बढ़ता गया, इतना ही एक्यूट हो गया, तो उतना ही एरिया भी कम हो गया ना रिकॉर्ड करने के लिए. यस और नो? यस, आई थिंक इट इज क्लियर. एनी डाउट्स प्लीज? एनी डाउट्स? आई एम वेटिंग इन द चैट बॉक्स. समबडी, एनी डाउट्स? Who all students are there? Kindly write your names. Okay, then there is another classification, house classification. Again almost same कि भाई कितना रिकॉर्ड है, कितना रेजिलियंट बैंड है, इमूवेबल बैंड है. तो हाउस ने बोला अगर वो 5 से 12 mm का हॉरिजॉन्टल बैंड है जिसे हम रिकॉर्ड कर सकते हैं तो वो क्लास 1 होगा. अगेन इट इज़ एक्सीलेंट. क्लास 2 3 से 5 mm, क्लास 3 लेस देन 3 mm. तो वही चीज़ है कि अगर हम वो जो हॉरिजॉन्टल पोर्शन जितना ज़्यादा होगा उतना अच्छा होगा हमारे लिए. ठीक है. Then I always say that this is an excellent book, Bernard Levin. If you know, it is a very not a very thick book. It is a very thin book. Excellent book on complete dentures. So if you can see that, you can see, if you see the junction of hard and soft palate in the class 1, you can see it is almost, the soft palate is in line with the hard palate. Class 2 you see a slightly more acute contour, and class 3 you see that it is totally down, it is going totally down, right? So class 1 में at least you see there is a at least greater than 5 mm of tissue available for post damming. It is ideal for retention. Okay, second is that 1 to 5 mm. Okay, it is medium, and class 3 is the most poor. So तो इसमें क्या है कि तुम्हें अगर वो चाहिए तो तुम यू कैन जस्ट यू नीड अ वेरी थिक डेंचर बेसिस. ओके, सो दैट टू गेट अ सील, राइट? क्लियर? Importance I have told you. Even it compensates. Now I will give you one homework. There is it compensates for the polymerization shrinkage. This one question I am giving my students. You find the answer where it is given. Okay, so even it increases the strength of the maxillary denture base. Okay, one important point is that in metallic denture bases or in metal denture bases, it is a high disadvantage that you cannot record the posterior palatal seal area. That means in relining, because it is in metal, तो आप PPS उसमें बहुत अच्छे से आप वो कर नहीं सकते. तो it's a disadvantage in metal denture bases that during relining you cannot record the PPS area, right, in metal denture bases. Okay, now I will tell you that there is something known as scraping of the master cast. You must have heard about the various methods of recording PPS. The various methods of recording PPS is that whenever you are going for the recording, one is a conventional method, one is the fluid wax technique, and third is the scraping of the arbitrary scraping of the master cast, and fourth method is the Silverman's extended palatal technique. That is totally bogus. Okay, now when we are talking about that, we should always check the how much resiliency is there and it is present where, right? जितना ज़्यादा कंप्रेसिबिलिटी जहाँ जिस एरिया में होगी, तो जो आर्बिट्ररी स्क्रैपिंग ऑफ द कास्ट होती है हम उसे उतना ही ज़्यादा स्क्रैप करते हैं उस एरिया में, क्योंकि जितनी कंप्रेसिबिलिटी अगर कंप्रेसिबिलिटी ज़्यादा है तो उतना ही वो दबा सकता है. जहाँ कंप्रेसिबिलिटी कम है वहाँ हम उसको कम स्क्रैप करते हैं. सो इफ़ वी सी दिस, आई जस्ट वांट यू टू पे अटेंशन टू इट. रिमेंबर, अगर मैं यहाँ सेंटर में हूँ अगर मैं सेंटर से टुवर्ड्स टेरिगो मैं आई एम जस्ट आई विल बी फोकसिंग ऑन दिस एरिया, राइट. तो सेंटर में देखो, इफ यू सी देयर इज अ 4 mm वाइड बट 1 mm की डेप्थ होती है यहाँ पे, ठीक है, क्योंकि यहाँ पे पोस्टीरियर नेजल स्पाइन है. विड्थ 4 mm रहेगी लेकिन डेप्थ हमारी 1 mm, तो मतलब कम कंप्रेसिबल है. ओके, तो यहाँ कम स्क्रैप करोगे. अगर मैं सबसे ज़्यादा जो हमारा क्यूपिड बो का जो सेंटर है वहाँ देखो 6 mm की विड्थ है और कम से कम 2 mm की हमारी क्या है, हमारी कंप्रेसिबिलिटी. मैक्सिमम कंप्रेसिबिलिटी और मैक्सिमम विड्थ इज सीन इन द हाईएस्ट स्लोप ऑफ द सेंटर ऑफ द of the anterior vibrating line, right. As we go towards the Hamlin notch, you see that the width also decreases and the depth also decreases. So in the center it is 4 is the width of the PPS. Then comes in the ये इसके मिडिल में आ गए यहाँ पे 6 mm. तो हम नॉर्मल बता रहा हूँ मैं, ऐसा नहीं है कि हर पेशेंट में ऐसा होता है. अंडर नॉर्मल सर्कमस्टेंसेज इफ वी गेट इट, एक्सीलेंट. तो इसी के हिसाब से हमें we can just arbitrarily scrape the master cast, but you have to see the compressibility. You cannot do it that much arbitrary, right? Otherwise what will happen, there will be if you over scrape the cast, what will happen, then it does not become a physiological method. It will over compress the soft tissues and there will be, as I have told, there will be arrhythmia, there will be rebound effect of the soft palate and the denture will come down. Okay, then there is something known as beading. Okay, you can do a single bead. देखो अगर आपको रिटेंशन करनी है तो आप कैन यू सी कास्ट में एक बीड डाल सकते हो, जस्ट एक लाइन सी. इन द कास्ट इट सेल्फ यू कैन जस्ट प्लेस अ लाइन विद द हेल्प ऑफ अ बर. यू कैन जस्ट प्लेस अ सिंगल बीड, डबल बीड, आप एक लाइन. तो वहाँ पे हमारा वेन एवर वी आर गोइंग ऑन द मास्टर कास्ट आई एम टेलिंग, यू कैन जस्ट टेक अ बर and you can just place a line so that whenever you are doing the packing of the denture, that line is reproduced in the denture. तो वो बीडिंग होती है. बटरफ्लाई बीड भी होती है, सिंगल बीड भी होती है, डबल बीड भी होती है, बहुत सारी बीडिंग होती है, राइट. You can see it, single bead, double bead. Can you see these are 2 lines, okay, on the master cast. Okay, butterfly shape you can do it. Okay, ठीक है. So I have told that conventional approach can be followed, fluid wax technique, even ultrasound and arbitrary scraping of the cast. So conventional approach is normally done when we have you have taken the final impression. So on the trial denture you tend to record once over again in conventional method, right. Fluid wax method, once you have recorded the final impression, then in the PPS area we take the mouth temperature waxes and you can ask the patient to do the movements with the mouth temperature waxes. What are the mouth temperature waxes? Example of the mouth temperature waxes are the Correcta wax number 4. Write down Correcta wax number 4, Adaptol green, ADAPTOL, Adaptol green. Okay, Iowa wax, IOWA, Iowa wax, and last is your HL physiologic paste, HL physiologic paste. तो ये हमारे माउथ टेम्परेचर वैक्सेस होते हैं that that have a good flow at mouth temperature, so we can use these, but they are very technique sensitive. Okay, विंकलर ने बोला कन्वेंशनल अप्रोच के भैया के पेशेंट को बोलो. देखो I again say कि whenever you are making the impression, if I think my postgraduates are also attending this, I will say that never whenever you are recording the final impression, if you want a bubble-less impression, what we हमने बहुत सारे fundamental ये हैं कि we take a gauze and we just wipe off the saliva. Never do this, because you are actually milking the glands. You will see a lot of water droplets there after some time, so that might cause bubbles, that might cause the porosities in the impressions. So what we do is, best method is that we take a cold astringent mouthwash just before making the impression. Ask the patient to do with the help of cold astringent mouthwash that will cause vasoconstriction, and your salivary glands, salivary ducts will be free of the saliva. ठीक. कन्वेंशनल मेथड में वी यूज टी बॉल बर्निशन, है ना, हम करते हैं, हम पीपीएस मार्क करते हैं, टेरियोमैक्सिनी मार्क करते हैं. वी आस्क द पेशेंट टू से आ इन शॉर्ट विगरस स्पर्ट्स, वी ऑल डू दैट, जैसे हमने बताया था. ठीक है, एक बार ही करते हैं और उसके बाद देन, है ना, और हमने उस पर मार्क कर लिया सारा, एंड देन वी आर ट्रांसफरिंग दैट ऑन आवर स्पेशल ऑन अ डेंचर बेसिस. ओके, देन उसके हिसाब से हम अपनी उसको ट्रिम कर लेते हैं. ठीक है. वी कैन ऑल्सो यूज दी वेल्सेल्वा मैन्यूवर. These are the waxes, as I have already told. What are the waxes? Iowa wax, corrector wax number 4, Adaptol green, and HL physiologic, KL physiologic paste, right? You can see the painting of the wax with the on the posterior area after you have made the impression, and just place it and do the procedure whatever you are doing. Okay. You just keep it for under gentle pressure for about 4 to 6 minutes. Allow the material to flow. And again, I told that ask the patient to see 30 degree down the FH plane. Vishal, yes, I can explain the muscles producing action. See, what I'll do is, Vishal, when in the next in my next in my next YouTube session, I will explain the muscles of the alveolingual sulcus, how the muscle action on the dentures in the next class, definitely. Okay. First, I wanted to correct the maxilla. I hope it is clear. This is how we do the arbitrary scraping. Okay, Vishal, don't worry, beta. Next time पक्का यही कराऊंगा. I am on the complete denture series now. Okay. Okay. So this is how you do arbitrary scraping depending on the who will do this. This technician will do this, or dentist will do this. Remember is that you will do this. Patient should be there. This is how we do it. Mind you, this is a totally unphysiologic technique. The physiologic technique is only the fluid wax technique. Write down, this is a very important question that comes, because it will never over compress the area. The conventional and the arbitrary technique, to arbitrary scraping is the worst technique, to be honest. The best technique, if you ask, is the physiologic technique that doesn't over compress the area, is the fluid wax technique, right? Fluid wax technique. You can use ultrasounds. No. One more important thing is that question that is asked is that what are the there is another question that is given, and even I have found the answer. It is given in voucher. What is the emergency retaining force of a maxillary denture? Earlier I have given answer as PPS, but then yes, PPS, remember, is there are various explanations to it. Now tell me one thing: is PPS activated always? Is PPS always activated? No. Remember is that PPS will never be activated when the patient is eating. It will not be activated under vertical forces. वहाँ तो contact बना ही हुआ है. But PPS is activated when there are tipping or incising or lateral forces. I do not want my denture to come down, and I do not want my seal to be broken while there are lateral or incising forces. देखो, हम PPS चेक कैसे करते retention? हम हैंडल लेते हैं ट्रे का, and we just do like this in the opposite direction कि डेंचर बाहर, हमारी ट्रे बाहर आ रही है कि नहीं आ रही है. So remember is that whenever we are recording, okay, the PPS, to check it, we just give a incising force or a tipping force. So our PPS is not activated every time. It is only activated whenever there are incising or lateral forces. First thing. Okay, got it? Second thing is that two important thing that you should understand whenever if somebody asks you that you are recording the PPS with the help of a low fusing compound, okay, another you are recording the PPS in second case with the help of your fluid wax technique. So the mouth temperature wax अगर उसने कांटेक्ट किया है हमारे टिश्यूज को तो कैसा आएगा, नहीं किया है तो कैसा आएगा. सो आई एम डिवाइडिंग इट in if, write down if the low fusing compound, write down if it has good contact, if it had a very good contact with the soft tissues, it will have a matte finish. Low fusing compound with good contact during while you were impressing upon it, if it is wonderfully recorded, it will have a matte finish. It is exactly opposite in cases of waxes. If there is if there is a good contact, they will be glossy in nature. It will appear very glossy. But vice versa, in the low fusing compound, if it has not, if it doesn't have a good contact, it will more be shiny. But in case of wax, if there is no contact, it will have a matte finish. I hope things are clear. Okay. Another thing is that never consider fovea palatini is the landmark to, in some books, and even it is given that that some people only take this criteria of checking the fovea palatini, but kindly don't use this as a landmark, because this is not a universal landmark. In more than 40 to 50% of the population, it is not there. Fovea palatini is not there. So you cannot take this criteria for marking the PPS. It should never be taken, otherwise you will be short. Okay. Right? I've told you about over post damming and everything. Okay. I'll just tell you some indications and contraindications of relining. We will take this small topic in 10-15 minutes and then I will go ahead. Okay. Now what happens is that first understand what is relining. Okay. Relining, I think I took this topic. I think relining. I'll take another topic. Do you want me to take relining, students? If you want, I will do it right now. Do you want me to take the topic of relining in 10-15 minutes? Vishal, I'm waiting. You can say yes or no. There is a small topic, I just wanted to finish it. Okay, I will take it. So देखो होता क्या है, आपने आज डेंचर दिया पेशेंट को, 6 महीने बाद वो लूज हो गया, इल फिटिंग हो गया, तो डेंचर में चेंजेस आए कि सॉफ्ट टिश्यू में चेंजेस आए? तो इट इज़ जस्ट लाइक कि आपने पेशेंट को डेंचर आपने अपने घरों में देखा होगा, आप घर अपनी दादी या मम्मा को बोलते हुए कि भाई आपने स्वेटर खरीदा आज और अगले साल हम क्या बोलते, स्वेटर छोटा हो गया. और भाई स्वेटर छोटा नहीं होता, बच्चा बड़ा हो जाता है, इसलिए नहीं आता है. तो दैट मीन्स डेंचर में चेंजेस आए कि जो डेंचर बेस का जो एरिया है, सॉफ्ट टिश्यू का एरिया है या हमारा जो एरिया है, उसमें चेंजेस आए. डेफिनेटली उसमें चेंजेस आए. डेंचर तो वही है. तो इसका मतलब है कि हमारे सॉफ्ट टिश्यूज़ में चेंजेस आए, उसमें स्पेस बनी. तो अगर हम किसी तरह सेम डेंचर बेस में सिर्फ वो स्पेस भर दें, तो इसका मतलब हमने क्या किया, रीसरफेस किया ना अपनी सरफेस को, डेंचर बेस को, टिश्यू सरफेस को रीसरफेस कर दिया. उसमें एक नया, उसमें जो स्पेस थी अगर हमने भर दी एक नए मटेरियल से, तो काम हो जाएगा, फिट इंप्रूव हो जाएगी. बिल्कुल सही है. तो बेसिकली अकॉर्डिंग टू विंकलर, इट इज़ द प्रोसेस ऑफ एडिंग some material to the tissue side of the denture to fill the space between the tissues, okay, to improve the fit of the denture. Okay, got it? Indications, बेटा देखो एक चीज याद रखना कि minor to moderate resorption you can do relining, but your severe resorption becomes the contraindication for relining. Write down, the severe ridge resorption becomes the contraindication for relining. Immediate dentures can be relined 3 to 6 months after the original construction. When the patient cannot afford new dentures, is very very poor patient who cannot afford, you have to do it. Wow. Geriatrically and chronically ill patient who cannot undergo these steps, वो 3-4 बारी आ ही नहीं सकते, तो क्या करोगे? रिलाइन कर दो, फिर क्या करोगे? ओके, तो देर यू कैन contraindication. I have told you that always remember is that whenever there is an excessive resorption, you know it is a contraindication. हम बोलते हैं जब भी, अब जैसे फॉर एग्जांपल कोई पेशेंट आया आपके पास डेंचर स्टोमेटाइटिस का, यू विल डू रिलाइनिंग और टिश्यू कंडीशनिंग? टिश्यू कंडीशनिंग करेंगे, रिलाइनिंग नहीं करेंगे. तो वेन एवर देर आर अब्यूज टिश्यूज, यू डोंट डू इट. TMJ disorders, TMJ problems, don't do it. ठीक है. when जब आपका डेंचर बेस ही पुअर क्वालिटी का है, तो क्या आप इम्प्रूव कर सकते हो? डेंचर बेस का बाहर का एरिया कोई प्रॉब्लम है, कर सकते हो? मान लो उसमें पोरोसिटीज हैं, तो रिलाइनिंग कर सकते हो? नहीं, है ना. अनसेटिस्फैक्टरी जॉ रिलेशनशिप मतलब when the centric relation, write down in bold letters, when the centric relation and the centric occlusion doesn't coincide, it becomes a contraindication. Whenever there are severe bony undercuts, don't do relining. Unsatisfactory jaw relationships, don't do relining. ठीक है. तो basically you can use various materials. I have told you, you can use your resin based, you can use your silicone based materials. Okay, we ask the patient to avoid wearing the dentures for relining around 48 hours before the procedure. Okay, there are static methods, there are better. This I will not go into the details, because one more important point is that whenever you are going for relining and rebasing, all we use a closed mouth technique. Write down, we use a closed mouth technique. Why? Because we do not want any increase in the occlusal vertical dimension. ओके, ओपन माउथ इम्प्रेशन नहीं लेते हैं, इसमें क्लोज माउथ इम्प्रेशन ले जाते हैं. तो भी आज हम सबसे पहले पेशेंट आता है, फिर चेक करते हैं, ठीक है, थोड़ा बहुत उसमें मूव कर रहा है, रिजॉर्प्शन कम हुई है, ज़्यादा नहीं हुई है. हम सेंट्रिक रिलेशन को अगर सेंट्रिक रिलेशन गलत है उसमें, या VD गलत है, काइंडली डू नॉट डू रिलाइनिंग. इट बिकम्स अ सीवियर कॉन्ट्राइंडिकेशन. मेक अ न्यू डेंचर. ये बहुत इंपॉर्टेंट चीज़ है जो मैं बता रहा हूँ. कैन यू इंक्रीज और डिक्रीज दी VD बाय रिलाइनिंग? नो. पेशेंट आता है जिसकी दिस इज हाउ द क्वेश्चंस आर आस्क्ड. if there is a patient with a reduced or increased VDO in the denture, can you correct it with relining? No, don't do it. डेंचर प्रिपरेशन करते हैं, डेंचर की बॉर्डर्स को हम 1.5 to mm रिड्यूस करते हैं, डेंचर को अंदर से 0.5 to 1 mm रिड्यूस करते हैं. वी डू बॉर्डर मोल्डिंग, वी मेक फाइनल इंप्रेशन विद द क्लोज माउथ टेक्निक, और उसके बाद हम फ्लास्किंग मेथड या आर्टिकुलेटर या जिग मेथड से हम उसको कर सकते हैं. राइट, गॉट इट. So you can see we are trimming the denture. Okay, if I am chair side relining, kindly you don't use such materials. Okay, so we have various articulator, jig and flask method. We can take it as a separate topic. rebasing का क्या मतलब है? rebasing का मतलब है उसमें हमने पूरा का, जैसे मान लो पोरोसिटीज आ जाती हैं और एंड देयर इज नो फिट, यू सी दैट टोटल वाइट डेंचर आया है, तो आप क्या करोगे? यहाँ तक फाइनल इंप्रेशन, बॉर्डर मोल्डिंग फाइनल इंप्रेशन तक तो सेम क्राइटेरिया है. रीबेसिंग में जब आपने उसको एक बार आपने वो कर दिया, इंप्रेशन लेके आपने फ्लास्किंग कर दी, देन व्हाट यू डू, यू इन दी ड्रैग पोर्शन you get the imprints of the teeth. Okay, in another you get the denture. You remove the denture, you just remove whole of the denture base, throw it, and only the teeth portion you just place it inside the imprints of the teeth, and you can just mix another heat cure powder liquid and just pack it. So in rebasing, you are only using the teeth of the previous denture, but you are actually cutting the denture base, throwing it away and adding a absolutely new base. But इसमें एक और क्वेश्चन आता है, again you have to see that there should not be excess of material. Okay, there should not be excess of material, you have to be careful. Got it? ठीक है ना? otherwise they will be increase in the vertical. बेटा jig method में हाँ राशि definitely we will have, don't worry. Okay Rakshi M, definitely we will have a session. अगली बारी हम एक बारी mandibular landmarks करेंगे and then 2 sessions I will have of DM them. Okay, definitely we will have it. Can I take a impression through alginate instead of Bax or compound? See, for all practical purposes, I tell you, you can only make an alginate impression. See, if you are asking for a clinical point of view and not for exam point of view, then I can say yes, you can take it, alginate, yes, but it becomes much more advisable to make alginate impression, primary impression, whenever there are flabby ridges. Resorbed ridge का impression, mind you, जो compound से impression आता है वो किसी से नहीं आएगा. Got it? In short, MEA complete denture procedure बता दीजिए. I'll do it, there is no problem, but then in short में flasking problem होता है. Okay, बेटा एक काम करूँगा ना, what I'll do is I will take a I will take a lecture on DM on a compression molding technique. तो I'm not knowing the name of your dental bud polyclinic. I'm just seeing the name. Definitely when I will be taking a lecture on resins, I will definitely teach you regarding the flasking and everything. I will take it, don't worry. ठीक है, so you can take it. Any doubts? Don't worry. I have taken all the. In the next class, I will be teaching you the landmarks of mandible. Okay, and then we can. Okay, Kotsav, no problem. Okay, any questions in today's lecture? I hope it is advantageous. I hope you people are learning with these YouTube sessions. बेटा जिग में बेटा इसमें जिग में क्या होता है कि एक सेकंड रुको, I'll just tell you. जिग में ना what I'll do is I'll provide okay, Dr. Kotsav, no worries. I will provide you pictures for jigs. Okay, जिग में क्या है कि हम उसे क्लोज ही उसमें करते हैं. ठीक है, तो वो उसमें बेसिकली हमारी वर्टिकल डायमेंशन इंप्रूव नहीं होती. एक सेकंड, इफ आई एम हैविंग, आई जस्ट वेट. Just a minute, if I am having. Yes. Okay. देखो जिग और आर्टिकुलेटर मेथड इज ऑलमोस्ट सेम. देखो हम क्या करते हैं, ये देखो, कैन यू सी दिस. हम क्या करते हैं, ओके देखो, आपने एक कास्ट बना ली, सुनना मेरी बात, ठीक है, आपने कास्ट बना ली, आपने प्राइमरी इंप्रेशन, आपने इफ यू आर इन रीलाइनिंग, आपने क्या किया, आपने डेंचर है आपके पास, विद यू हैव अ बॉटम मोल्डिंग एंड फाइनल इंप्रेशन. व्हाट यू डिड इज यू पोर द कास्ट. ओके, आपने कास्ट बना ली, आपने अपर मेंबर ऑफ द आर्टिकुलेटर, या एक जिग होती है आर्टिकुलेटर जैसी मान लो बिल्कुल, ठीक है, आपने अपर मेंबर पे उसको माउंट कर दिया. फॉर दिस इज द आर्टिकुलेटर मेथड. आर्टिकुलेटर जिग मेथड इज ऑलमोस्ट सेम. आपने अपर को माउंट कर दिया. नीचे जब आपने, जस्ट अ मिनट, नीचे वाले उस पे, कैन यू सी, नीचे वाले पे आपने जो आर्टिकुलेटर का लोअर मेंबर है, आपने उस पे प्लास्टर डाल दिया, राइट. तो नीचे के इम्प्रिंट्स आ गए आपके, ठीक है. अब आपने देखना है कि आपकी, जब आप बंद कर रहे हो तो आपकी पिन नीचे इंसाइजल टेबल पे बंद होनी चाहिए. जब आपने इसको बंद किया, अब आप क्या करोगे, नाउ व्हाट यू डू इज, दिस इज अ दिस इज अ मेथड ऑफ आर्टिकुलेटर या मेथड जहाँ पे हम बेसिकली हम चेयर साइड रिलाइनिंग बेसिकली हम लेबोरेटरी रिलाइनिंग करते हैं विद द हेल्प ऑफ योर कोल्ड क्योर. आपने डेंचर हटाया, ठीक, डेंचर में से आपका जो इम्प्रेशन मटेरियल था वो आपने हटा दिया, वो हटा दिया. कोल्ड क्योर मिक्स करो, डेंचर के अंदर डालो, फिर से उसके ऊपर बंद कर दो और उसी इंडेंटेशन में चला जाएगा, तो उसमें वर्टिकल डायमेंशन इंक्रीज नहीं होती है. बेटा मैं काम करूँगा ऑल्सो, आई नो दिस इज डिफिकल्ट टू अंडरस्टैंड. I will definitely make a make a pictures. I'll just arrange pictures and next time I'll show you. Okay. So I hope this session, Vishal, Kotsav, I hope these sessions are helping you in your studies. Yes. So God bless you. Stay blessed. Study hard and make your parents and